All welcome Dr. Ray Malilay, our moderator for session 1.
Good afternoon. I'm Dr. Ray Malilay, the moderator for this session on choosing between surgical and non-surgical treatment approaches to address locally advanced breast cancer. We all know that breast cancer is the #1 cancer now worldwide, and it impacts most especially in the country. And I would like to thank the Southeast Asian Breast Cancer Summit for choosing locally advanced breast cancer. This topic is relevant and germane, especially in our country where we see a lot of these patients at this stage. And so to illuminate us on this very important topic, we have two speakers. One will do it to us virtually, and one is present with us this afternoon. So to start off, I would like to call Dr. Rosita Abdul Malik to be our first speaker. Dr. Malik.
Hi, good evening everyone in Manila and also virtually. First of all, I would like to thank the chairperson and also the organizing committee for inviting me to this event. I will share my slide. All right, I hope everyone there would see my slide now. Right, so once again, good afternoon everyone. And we are here to discuss about this topic this afternoon, choosing between surgical and non-surgical treatment approaches to address locally advanced breast cancer. So I'm Rosita Abdul Malik from Clinical Oncology Unit, University Malaya Medical Center, Malaysia. We'll start with looking at the breast cancer incidence. So as we all know that breast cancer is the commonest cancer in the world and among women, and it has surpassed lung cancer recently. And there was about 2.26 million new cancer cases were diagnosed in 2020, and it's constitute about 11.7% of all cancers, and about 45.4% were in Asia. So this was data from Global Can 2020. And locally advanced breast cancer in Europe and US represents about less than 10%. However, in low resource countries, it can go up to about 60%. And this mainly due to several factors like minimal breast awareness program, neglected early breast cancer, and also limited use of multidisciplinary approach. So histopathology of locally advanced breast cancer is relatively similar to early breast cancer in most neglected cases, and we see these patients with advanced age. However, some may be aggressive intrinsically. And overall, there are slightly higher percentage of HER2 positive and triple negative subtypes of breast cancer in locally advanced breast cancer. Inflammatory breast cancer, which is a specific entity of locally advanced breast cancer, is a rare and aggressive tumor. And overall, locally advanced breast cancer has higher risk of relapse compared to early stage tumors due to tumor burden and possibility of micrometastasis disease at diagnosis. Let's take a look at the staging of for breast cancer. A quick one. We know that breast cancer is staged using the TNM staging, and T would represent the primary tumor, the size and also extent of the tumor. N is describe the lymph nodes, the extent of the lymph nodes, and M is describe the spread of the cancer, whether there's any distant metastases or not. And just to take a note that there was summary of changes in the AJCC 8th edition, the new staging system, which incorporates grade, proliferation rate, hormonal receptors, HER2, and also multi-gene panels as stage modifiers in prognostic staging group. And we saw with these changes, some of the tumors may be upgrade and some may be downgrade depending on the profile of the tumor. Right, so basically locally advanced breast cancer include patients with any of these features. So importantly, they might have advanced primary tumors, whether they have T3 or T4 tumors. T3 are those with more than 5 centimeter in greatest dimension, and T4 any size with direct extension to the chest wall and also or to the skin, and a specific entity of inflammatory breast cancer. And some of them may have advanced regional lymph nodes where there's involvement of lymph nodes not only at the axillary region but also at the internal mammary, and N3 where it also may involve ipsilateral, infraclavicular, and also supraclavicular lymph nodes. If we see that locally advanced breast cancer actually covers stage 3 tumors and a small proportion of stage 2B with T3 and not M0 disease. So locally advanced breast cancer by definitions, widely used definitions are those with stage 3 as mentioned, and some with stage 2B, T3 and not, and these are some of the patients that have operable disease up front. So an inflammatory breast cancer also represents quite a number of locally advanced breast cancer, that is about 8.5%. So what are the non-surgical treatment approach in locally advanced breast cancer? We have systemic treatment that will include chemotherapy, hormonal therapy, targeted therapy. And these systemic treatments, later we will see that the flow work of management of locally advanced breast cancer suggested that systemic treatment should be the initial treatment, and that's why majority as neoadjuvant treatment. Some of these systemic treatment are used as adjuvant treatment that is given post-surgery, and also some will be given as palliative systemic treatment in cases where the locally advanced breast cancer is inoperable, and some of them might not respond well to systemic treatment, and later use of chemotherapy or systemic therapy as a palliative treatment. Other than that, radiotherapy, majority are being used as adjuvant treatment to reduce local recurrence. And in certain cases, it can be given as palliative treatment to control bleeding in very locally advanced breast cancer with bleeding. Right. As a whole, locally advanced breast cancer should be approached multidisciplinary, and this will include discussion with breast surgeon, oncologists, radiologists, pathologists, and also breast care nurse. And we see this flow chart. It shows that multimodality treatment is what advised for locally advanced breast cancer management. And initial therapy should be systemic treatment, and the initial therapy would depend on the tumor and the patient characteristics. So it is important to know what types of breast cancer the patient is having. And after initial systemic treatment, those patients would undergo surgery for those with operable tumor. And if the tumor remains inoperable, then further systemic treatment, if appropriate, would be needed, or in certain cases, radiotherapy would be given. And if the tumor still remains inoperable, they will be treated as advanced breast cancer, in which the treatment would be individualized. So just to share Malaysian clinical practice guide, where they divide locally advanced breast cancer into operable and inoperable tumor. And those with operable would have options of a mastectomy and axillary surgery, or they would have a neoadjuvant systemic therapy and followed by surgery. For those with inoperable disease, as we know, the initial treatment should be systemic treatment and follow with this diagram. If it is renders operable, then surgery and adjuvant treatment. For those with inoperable, then the treatment will be individualized. So before we start the treatment, it's very, very important to define the cancer, and again, to emphasize the importance of history and also clinical examination of the patient. Radiology evaluation is also important to look at the extent of the tumor, the size, the involvement of lymph nodes, and also if there's any presence of distant metastasis or spread. And pathology also plays an important role to determine the tumor characteristics and also the likelihood of response. As we know in the literature that lobular carcinoma, mucinous, and metaplastic carcinoma are some of the subtypes that might not respond well to systemic treatment. Okay, estrogen receptor, progesterone receptors should be determined together with HER2 status, and Ki67, that's proliferative activity, and also the grade of the tumors. And in certain cases, molecular BRCA testing is also indicated. So we can see from this diagram on the right that luminal type of breast cancer usually present with better prognosis and less aggressive, and those with triple negative usually behave more aggressive. So as mentioned, the approach of locally advanced breast cancer, as far as possible, neoadjuvant systemic treatment should be given, and these are some of the objectives of doing it. One is to render otherwise inoperable tumors operable and allow breast conserving therapy. Secondly is to improve outcomes in patients with locally advanced breast cancer or high risk of distant metastasis, that is the ability to eliminate micrometastasis early. Third is to have a rapid assessment of clinical response, so that certain tumors that respond poorly to the treatment, we can actually change the management. But this represents a very small percentage of patients, about less than 10%. And lastly is to provide individualized post-treatment prognostic information, in which it is very important now whether patient achieve pathological complete response or there's residual cancer burden, and this would guide us in the deciding the adjuvant treatment. So nowadays we are talking about pathological complete response, and this is defined as complete disappearance of any invasive cancer cells in the excised breast tissue and lymph nodes after the end of neoadjuvant systemic therapy. And we can see here that those patients who have HER2 amplified and basal subtype, that is triple negative, responds well with neoadjuvant chemotherapy, and it can go up to about 45%. And why this is important? Because achieving pathological complete response is associated with improved prognosis in breast cancer. Neoadjuvant chemotherapy also increased the rate of breast conservation. We have this NSBP B18 study done in 90s where they compare adjuvant versus neoadjuvant chemotherapy, and we can see that the lumpectomy rate was higher in the neoadjuvant patients, and also we can see that the response better in neoadjuvant chemotherapy. So in this short presentation as a whole for the management of locally advanced breast cancer, it is a very important clinical problem and a very challenging, especially in developing countries, and need to stress that it requires multidisciplinary approach and also multimodality treatments. And data on neoadjuvant treatment for locally advanced breast cancer is limited. There's no reason large RCTs that focus on this subgroup. And commonly it includes a mixture of early breast cancer and locally advanced breast cancer. And again, to emphasize the neoadjuvant systemic therapy in downstaging the primary tumor to bring to operability, and also to prompt treatment of subclinical micrometastases, and to evaluate response to treatment in guiding the adjuvant treatment. And primary surgical treatment might be suitable in selected patients, for example, operable resistant tumor like metaplastic carcinoma, those with multiple comorbidities not fit for chemo or systemic therapy, and those patients with poor access or availability to non-surgical treatment. I just want to share a case of locally advanced breast cancer. This Madam NK, 60 years, who presented with 1 year history of painless left breast lump associated with nipple discharge of a 2-week duration. So physical examination showed 5 centimeter hard lump at retroareolar region, no fixity to chest wall, overlying skin pocket, and there's a presence of serous nipple discharge. And she also have a 1 centimeter mobile axillary lymph nodes. So investigation done in September 2021, mammogram ultrasound showed suspicious left breast mass with axillary lymph nodes BRAT5. She underwent a PET CT as initial investigation showed suspicious lung nodules. So findings was there's hypermetabolic mass in the left breast with overlying skin involvement and satellite nodules. And she also have round sub-centimeter left axillary lymph nodes, about 0.9 centimeter. This was uncertain because patient just had COVID vaccination about 2 weeks ago before the scan, and it can also be either post-vaccination lymphadenitis or early nodal metastasis. And also findings of ametabolic lung nodule at right upper lobe. So biopsy was done, revealed invasive breast carcinoma grade 2, ERPR negative, HER2 3+ with no lymphovascular invasion. So this patient is defined as having locally advanced HER2 breast cancer and was discussed in the multidisciplinary team meeting, and the consensus was to give neoadjuvant systemic therapy followed by surgery with the aim to provide effective systemic treatment to eliminate micrometastases and also to downstage the tumor. So options of systemic treatment was given chemotherapy plus anti-HER2, and options of either chemotherapy plus trastuzumab or chemotherapy plus trastuzumab with pertuzumab. Patient underwent neoadjuvant systemic treatment, chemotherapy, and trastuzumab. Just to highlight that trastuzumab given concurrently with chemotherapy consistently showed better disease-free survival and overall survival as compared to sequential regime. Right, so this patient, after the neoadjuvant, underwent left mastectomy and axillary clearance in February 2022. HPE revealed residual IDC grade 2.6 centimeter with no lymph nodes involvement. And radiotherapy to left chest wall at SCS was given, and she was planned to complete another 14 cycles of trastuzumab, and currently she's on cycle 10, and she is doing quite good. So that is from me. Thank you for your attention.
Thank you, Dr. Malik, for that wonderful lecture. So Dr. Malik talked about PCR a lot. This is actually the holy grail in terms of treatment for breast cancer, achieving PCR, or pathologic complete response. We'll have our next speaker in the person of Dr. Cheng Har Yip. Dr. Yip is with us this afternoon. Dr. Yip.
Can I have my slides? Okay. Thank you. Can you hear me? Yes. My slides. Are my slides coming up? Oh, yes. Thank you very much. Okay. So I'll be talking about the surgical management of locally advanced breast cancer. Advanced breast cancer is a common presentation in developing countries, and the reasons given for late presentation because of a strong belief in traditional medicine, ignorance, and geographical isolation. Advanced breast cancer can be divided into locally advanced breast cancer without distant metastasis and metastatic breast cancer where distant metastases are present. Now, the reasons for late presentation, this is a study done by one of my colleagues. We found that fatalism is a major theme because patients think that breast cancer is a death sentence, so why bother to treat it? Belief in alternative therapy as an active form of treatment and a more acceptable option of treatment is found in many of these women, and also a lack of individualistic and autonomous decision-making, with women playing the role of a dutiful wife and daughter, and they actually need sanctioning to see a doctor. And the decision is usually made by their family and not by themselves. This is a traditional medicine. In Malaysia, they go to this thing called bomo, which is a Malay traditional man. You see scars form on the breast. When I see scars like this, I always say, you've been to that bomo in Shah Alam, because there's a famous bomo who does this. And this lady has scars on the breast, and she also has scars on the back because she also had pain in the back because she had bone metastasis. Now, this is a Chinese lady. She was diagnosed when she was 36 weeks pregnant, and we had all agreed after delivery, we're going to remove your breast, and they're going to have chemotherapy, everything. But after delivery, she absconded, and what happened was that she wanted surgery, her husband wanted surgery, but her parents wanted her to seek traditional medicine. So, again, this is the problem. They cannot decide, and they will defer to their parents. So she presented 5 months later with a large right breast mass, and she had alternative therapy with jaw sticks. These pink things here are jaw stick burns. Okay? So how do we manage it? We need, with a combination of chemotherapy, surgery, radiotherapy, hormone therapy, targeted therapy, immunotherapy, you can get actually very good 5-year survival rates and also very good local control rate. If operable, surgery should be offered first because there is usually a need to control symptoms from a very ulcerating large lump. But the definition of operability is variable. I'm sure the surgeons here would know what somebody say operable, another surgeon may say inoperable. So first of all, when we see the patient, pain control, you can see this lady here, dressings, control of infection, control of the smell, and then at the same time, we investigate like what Dr. Rosita says. The control of smell, I'm sure some of you will know that it's very smelly. A locally advanced ulcerating tumor is very smelly. And I must say that when I see this, especially I was pregnant, I just wanted to vomit. And that's very actually distressing for the woman when somebody vomits in front of them because of the smell. So charcoal is a very good it actually absorbs the smell. We also put Clutch Fragile tablets, and this actually can take care of the smell in most instances. These are calcium impregnated dressings. They are expensive. What we do is we actually get charcoal, crush it, and put it in between the dressings, a cheap form of a dressing. Exudate, you know that they will actually ooze and ooze and ooze, and their protein can drop. Sometimes the whole bed is wet. I'm sure we've seen women like this. And there are actually special dressings that will absorb it. But what I find is that these are expensive. If you use baby diapers, it's just as good. It will absorb the liquid that keeps flowing out. Wound dressing is an issue. When the wound is bad, it can take the nurses 1 hour to dress the wound. And people have tried different wound dressings, even honey, which I don't like because they always bring the ants with them. I really don't like honey, but they say it's very good. Control of bleeding. Some of them come bleeding, and Dr. Rosita said just now, you can actually do hemostatic radiotherapy, good option. In fact, recently, just 2 weeks ago, I had a patient who came with an HP of 3% from bleeding. Locally advanced, first presentation, she had lung mets. She died within a week. She had no time for any treatment at all. So this is a lady I saw some years ago, 3% bleeding, 3%, was on traditional medicine for over a year. This one, we did an emergency mastectomy. It is operable. Because if it's operable, the best form of treatment is to cut it out. Because these women, by the time they come, they want the tumor out. That's the best time to get them to agree to surgery, because I said, if you don't, you're going to bleed to death, then they will agree to surgery. You stop the bleeding, they will run away again. Okay, primary closure is possible in this sort of thing. I'm just talking about closure of the skin. How do we do it? This is an abdominal advancement flap. You know, there's a lot of skin at the abdomen. We actually mobilize everything and pull it out, and we can close the skin. This one, we can also do local flaps. So we take out this lump, and the skin, there's a lot of skin at the back, so we just mobilize the skin and pull it out. Now, this is an Indonesian woman who came with a malignant phylloides tumor. Now, malignant phylloides do not respond to chemo, so you cannot do chemo to shrink it. But usually they are operable. So first, assess operability. And, you know, we actually managed to take the whole thing out. The tumor was 7 kilograms. This is heavier than a newborn baby, okay? And we left a big defect. How do we close this defect? You'll be surprised. Primary closure was possible. We just mobilized everything, abdominal advancement flap, and we closed the skin, and she's still alive. Because malignant phylloides actually is not as bad as the infiltrating ductal. This one, after chemo, still had this ulcerating lesion. This had neoadjuvant chemo. So we managed, sometimes after neoadjuvant chemo, it's also not quite operable. This one we managed to operate. We also did a local flap. Now, this one, primary closure is not possible. Just now I talked about primary closure. Now, this one, you will need a lead dorsi flap. So she came with this mucinous carcinoma. We took skin from the back. So she has a scar at the back and a scar in front. But because it's mucinous, stage 3, she was still alive 20 years later. Now, is this inoperable? Now, this is a 30-year-old lady diagnosed with early breast cancer, and she's educated. Refused treatment and returned 1 year later with a large ulcerating lesion. She had sought traditional treatment all over Malaysia and Indonesia. Now, her brother actually is a medical student with us, you know, so he's an educated woman. When I showed this, they say, oh, cannot operate. You would have to give chemo first. But this lady's hemoglobin was like 27, you know, and she actually, no, was only, 12 or something. Anyway, she needed quick treatment. So it really depends on the surgeon's assessment. Is it operable? Okay? Surgery was required for quick local control because it was bleeding, it was infected. And we can't do SSG for skin cover, you know, split skin graft, because the tumor will grow as before your skin graft heals, you know. So we always have the full thickness skin closure, and we usually get the lead dorsi flap. So we did this, and she lived maybe about 2 years. This is even worse. It's a 34-year-old lecturer, so she's not uneducated. Okay? Now, she had this right breast lump for 4 years. She was unable to walk for 3 months because of the weight of this. If you see her skin there, you see her face there, you know how big this one was. When we took it out, it was more than 10 kilograms. It was the weight of 3 newborn babies. So, of course, she cannot walk because of the weight. She was admitted in critical condition with dehydration, renal impairment. So we thought this is the last bit, she's going to die. But when we resuscitated her, she actually recovered. And then we said, is this operable? Because it took the nurse hours to do the dressing. And the assessment of operability is important. She came to us saying it's inoperable. But actually, if you pull up the skin, there is actually a lot of skin at the side, you know. So we took out the whole thing, and there was a big gap, and we closed it with a lead dorsal flap. She went on to live for 1 year. She had lung metastasis later, and she died of lung metastasis. But with 1 year, she had good quality of life. She could walk, she could go out with her children. You know, we gave her 1 year's MC, thinking she was going to have chemotherapy and radiotherapy. Nope. She took that 1 year MC and actually spent time with her children. So it's a patient's choice, you know. This lady has liver metastasis, but when she came to us, she said, I want this ulcer out, you know. Liver mets, should we take out the breast? It's not going to cure her. And bad liver mets also, not just one mets, it was the whole liver. But for quality of life, we took out this lump. We did a mastectomy, did a lead dorsal flap. Okay, big defect, and we covered it with a lead dorsal flap. She went on to live 3 more months only, because after that you would say, oh, we can have chemotherapy, prolong your life. Absolutely refused. She came to us just to get this thing out. Now, these are things that are absolutely not operable, okay? I'm not a hero. I can't operate on everything. This one cannot. This one cannot. Okay? These are not operable. So, that's my last slide. Now, for patients presenting with advanced breast cancer, counseling is very important, because the reason why these patients come late is because they don't want to see us. They don't believe in Western medicine, you know, and they are not compliant. They default treatment, like I have seen in all these women. Health education campaigns need to emphasize that breast cancer can be cured with early detection, and that alternative therapy is unproven and ineffective. Finally, surgery is the quickest and most effective mode of local control. I don't know whether there's medical oncologists here, but they usually will say, what, you want to operate on this? Let me give chemo first. I say, no, no, no. We want to operate first. Because these women are not compliant, okay? If you give chemo, it's very likely you won't see them again. And experience is required to assess operability, and not only assess operability, the best choice of skin closure. You might need to get in a plastic surgeon, but in Malaysia, usually the breast surgeon will do this. I will call in a plastic surgeon if I find that I cannot get any skin from the back or skin from the side or whatever. Okay, thank you very much.
On the surgery for locally advanced breast cancer. Our next speaker is actually will be our reactor for the 2 previous speakers. She comes to us as the Vice President of the Philippine Society of Breast Surgeons. She is involved in the training of a big government hospital in the country, East Avenue Medical Center. She is in charge of the breast unit, not only at East Avenue, but also at the National Kidney Institute. So she walks, she talks very well, and she walks her talk. To react to the previous 2 speakers, let me call Dr. Claudia Ordonez. Claude?
Thank you, Dr. Malilay, for that wonderful introduction, and thank you to SEABCS for having me today for the wonderful invitation. So, in the first lecture, sir, by Dr. Malik, we have seen that she had put stress really on the importance of our molecular subtyping. So basically, that is the ERPR HER2/neu of breast cancer. So even for locally advanced breast cancers, we have learned that, and that's what we do, that we still try to decide whether we should go ahead with surgery or not and give neoadjuvant first based on the molecular subtype of patients. We have seen, basically, we need to know which subtypes are responsive to chemotherapy, and in that also in her lecture as well, she has stressed the importance of multidisciplinary care for all our patients. So fortunately, this is now becoming more of the mainstream in our hospitals in the country so that we can better help our patients, because especially for locally advanced breast tumors, patients need to be taken care of by different specialists from different disciplines. Also, we have seen Dr. Malik has stressed on the importance of neoadjuvant. Basically, it would be able to achieve PCR, which gives the patients with locally advanced breast cancer a better prognosis. And also, long ago, when a patient has locally advanced breast cancer, the only surgical treatment would be mastectomy. But with the advent of neoadjuvant treatment and more targeted neoadjuvant treatment, other forms of surgery are available for our patients. Now with Dr. Yip, that was a very interesting lecture. The pictures you've showed us are very familiar to me. And also, it's nice to know that it's not only in the Philippines where traditional medicine is still common, but in Malaysia as well. Well, it's not nice to know, but it's enlightening to know that it's not only in the Philippines that alternative treatment and traditional healing is a problem for our patients. Also, well, currently, as Dr. Malila has mentioned, I work in a government hospital. And, well, when I was in training, it seems we had more locally advanced breast cancers at that time. But at this time, we had a study recently, and we found out that our locally advanced breast cancers are down to only 1/3 of all our patients, which is very, I think, inspiring and promising. Also, we have seen that in Malaysia, it was interesting to find out that there are other kinds of dressings that may be of use for our patients. So because it's only now that I found out that, well, maybe charcoal can be used for our patients, because most of our patients are indigent, they're financially challenged. So that's one thing we can try. But yes, it's true, our locally advanced breast cancers patients come to us for many reasons. And one would be lack of finances. Number 2 would be fatalism, as Dr. Cheng Haryip has mentioned. And number 3, I think it's also, it's something that we need to be able to act on also, is the decision, being able to decide for herself, for all the women in our country. Because in our country, it's common to see women to be still dependent with regard to their decision making, dependent on their family, dependent on their husbands, and to their partners. So thank you.
Thank you, Claude. We will shift gear from a government hospital. We will go to a prominent private hospital in the country. It is a privilege and honor to call a friend from the medical city. She's a clinical associate professor. I think this is Ateneo School of Medicine. So, Dr. Pierre Cao, Pierre, can you hear me? Dr. Cao?
Yes. Good morning, Dr. Malilay. Thank you for that kind introduction, and congratulations to the organizers for this a wonderful conference. I'd like to react to both of our speakers. For Dr. Malik, I'm really glad that you mentioned about the multiple modalities for treatment, the neoadjuvant chemotherapy, which we have been doing here in the country, not only for those inoperable ones, but also for those operable ones with the triple negative and the HER2 positive. More and more patients are more educated now, and we can offer all of these treatments that are available to give a complete pathologic response. And I also actually wanted to, as a question later to Dr. Malik, how soon do you want us to do surgery on patients that you do neoadjuvant chemotherapy on? Is it after the full course of the chemotherapy, or is it just after like 4 courses? No, maybe in a while. You could also give us information on that. And to Dr. Shenghar Yip, it's interesting to see that we have common patients. In this day and age, we still see a lot of those big ulcerating masses. And it's, as I mentioned, it's very fitting to see them compared to our Western counterparts, wherein they don't really see these types of large tumors. Now, I love that you do more full thickness flaps than split thickness skin grafts. Like in our country, we do more of the split thickness skin grafts. Because we just want to immediately close the wound and let the patient go on to the next cycle of treatment. And you mentioned also about patient's choice, which is very important. A lot of them really do fear the surgery, and they would just, if you don't do surgeries on them, they would just leave. That is true. But we still try to offer what is ideal, which is neoadjuvant chemotherapy. Yes, we also do see a lot of them doing alternative treatments, especially for the even for the educated patients. And it's surprising in this day and age that we still see them, but we do. I love that you mentioned about the diapers, which I also recommend to my patients. They don't stick and they're cheap. And I personally use sodium hypochlorite also. And charcoal is indeed a good alternative. So those are my reactions. And even if I do come from a private hospital, I still see these large tumors as well. Thank you.
Thank you, Pierrette. So for the interest of time, we can only entertain 2 questions. So first question from Dr. Remy Caris Velasco. She actually asked 5 questions. So I'll just choose one. Is there a role for surgery therapy alone for patients with low risk, locally advanced breast cancer? Has anybody read on anything on the role of primary chemotherapy alone for locally advanced breast cancer? Dr. Malik, Dr. Yip, Claude, Pierrette, anybody?
Dr. Malilay, I'd like to answer. I don't think there are any randomized controlled trials yet that we have on just doing pure chemotherapy alone and no surgery. I think the other surgeons would agree.
Yes,
You know,
I
in
would
those,
agree with that as well.
so-called
Usually
patients-
it involves multimodality treatments unless refused by patient for surgery.
Yeah. Because sometimes neoadjuvant chemo, the tumor actually disappears. And then you're asking whether there's a need for surgery if you cannot feel it. Right now, no. There's no, like you say, no control trial to see whether it's safe not to do surgery. So we all tend to do surgery. But I have patients who absolutely refuse surgery. Then we would, I don't know, Dr. Rosita, would you just give radiotherapy to the breast even without surgery?
Okay, to share, I actually have one patient who actually have locally advanced breast cancer. We give chemotherapy, neoadjuvant, and she responded very well and refused surgery. So we can't do anything but to just follow her up. And she is, if I'm not mistaken, she's HER2 positive. So I did gave her anti-HER2 trastuzumab. However, she progressed later. So I think in her case, I mean, this is just one case that I can share. But I also did gave her radiotherapy, hoping to have a good local control.
Thank you.
So she actually had distant metastases without local recurrence. Yeah.
Thank you, Dr. Malik and Dr. Yip. Claude, anything to add?
Well, you have mentioned, sir, you have mentioned about that study, sir, that they're doing now at MD Anderson, but for these patients, they have chosen the more aggressive types, or triple negative breast cancers and with complete pathologic response, but it's still under study, sir.
Yeah, there are actually 3 trials now ongoing. The lead institution is MD Anderson. They're doing primary treatment, non-surgical treatment for triple negative and HER2 new positive disease. So if after their neoadjuvant treatment, the patient develops PCR based on imaging and repeated core needle biopsy, they observe the patient. But Dr. Akaw is correct. This is a phase 2 trial. There is no randomized controlled trial yet to address the question of Dr. Remy Velasco. Can I answer this? Can I ask this
just say
question?
something about the split skin graft? I don't think it's a good idea. We always should have full thickness graft on the defect.
Okay. Thank you, Dr. Ayib. So, unknown. So, text message question. We saw how huge, this is addressed to Dr. Yip. We saw how huge locally advanced breast cancer can be managed surgically. But just to clarify, Dr. Yip, when do you say it is unresectable? What are your parameters?
I think, like I say in the beginning, inoperability is actually in the eyes of the surgeon. I've already said what one surgeon says inoperable, another surgeon will say operable. I think I showed examples of those that are really inoperable because they are many, many skin lesions. It's all stuck to the chest wall. But even so, you still can do it. You get a plastic surgeon to do it. But it really depends on the fitness of the patient, whether there's metastasis or not, to really decide whether you will do a major chest wall resection and probably bring the plastic surgeon in to repair the chest wall and all that. Anything is operable. It's just like how major you're going to do it.
You know, when I started doing breast cancer treatment in the University of Santo Tomas, the only treatment we know for locally advanced breast cancer treatment was surgery. And no patient of ours survived 2 years. And then in 1989 came the paper on neoadjuvant treatment. And so, not to disagree with Dr. Yip, so our thinking is, if there are, it's not the surgeon's call whether it is locally advanced. It's based on the physical, based on what appears, the presentation of the patient. If the patient has stage 4 disease, even if it can be removed, we do not remove it. We give the patient neoadjuvant treatment. If there are any other questions, we exceeded our session by 20 minutes, so I guess we will have to end. And on behalf of our speakers, Dr. Malik, Dr. Yip, and our reactors, Dr. Claude Ordonez and Dr. Pierre Cao, I thank you all for your excellent lectures and illuminating us this afternoon. Thank you, everybody.